Okay, I think it's 12:01. I think we should rock and roll. I hope everyone's having a great Friday. We have an excellent speaker today. We have Dr. Joe Holgus, and he is going to talk about eye movement desensitization and reprocessing therapy. Dr. Holgus is a licensed psychologist and received his PhD in counseling psychology from Texas Women's University and a Master of Public Health degree from Missouri State University. Woo woo! And a bachelor's degree from Indiana State University in Evansville. Dr. Holgus has worked with Missouri State University and Ozarks Public Health Institute as research and program evaluator for the last 16 years. We're very excited to have you. Take it away.
Well, it's hard to live up to that. Yeah. I am a licensed psychologist. I've been so since 1991. So, about 2 weeks after dirt was invented. I've been doing this work for, feels like my whole life. So just to give you a little bit of background, back in the day, when people were wanting to resolve trauma in their lives. And, I moved up here 25 or so years ago. Up here is Springfield, Missouri, by the way. Moved up from Texas. And when I was in Texas, worked in a variety of different kinds of settings, but worked with trauma survivors of one sort or another, whether natural disaster or actually a lot of them were adult survivors of childhood sexual abuse. And so back in the day, the predominant way that you work with folks that had trauma in their history was you tried to establish a safe environment with a small group of people, and then you start helping people tell their story, right? And so it was essentially capitalizing on desensitization. So if you can get them to tell the story, walk through it, correct, old distortions, things like that, reconnect with, reclaim affect, then people start to heal. But it is a brutal process. I mean, if you think about it, somebody talking about, various kinds of trauma, whether it's, childhood sexual abuse or rape or things like that, to go back through the story, every time you go back through is pretty tough. So fortunately, different methods of dealing with trauma have been developed. And back in the late 80s, there was a lady who was actually working on a PhD in literature up in New York. And she got some bad news. She was diagnosed with, I'm not sure what some kind of cancer. And she was trying to deal with it, and she would go on walks, and she would think while she walked, and she'd, her eyes would go back and forth as she was walking, and she was thinking. And she noticed that she felt a lot better after these things, and she got curious. Her name's Francine Shapiro, by the way. And so Francine started, experimenting some with her friends. She thought, this is weird. Is this just me, or is there something here? And so she worked with her friends and tried some different things. And sure enough, her friends reported some relief of things that had previously been very troubling. So she leaves her doc program in New York, goes to California, enrolls in a doctoral program in professional psychology out there, and completes her PhD in psychology, and does her dissertation on this method that today we call EMDR. And then from there starts refining the process, training people, and doing oodles and gobs of evaluation research to thoroughly scientifically evaluate the approach. So that what we have today is the fruits of those early efforts. So in dealing with trauma these days, when I work with folks, I go through a spiel to try to orient folks to what this stuff is about. And I say that, life is full of traumatic events, right? And by a traumatic event, there's sort of like two different types: trauma with the big T and trauma with the little t. So the big T traumas are, the catastrophic events, bad car accidents, tornadoes, natural disasters of various sorts, et cetera, et cetera. The little t traumas are the things that happen more frequently that aren't as dramatic and yet are very impactful. And we sort of, most of the time, we're just wired to process through these things. So the estimates are that, somewhere between, 95 and 98% of the things that we encounter that might otherwise be traumatic, we process through. So we're really designed, factory equipment, if you will, to be able to process through things. But every so often, for no clear reason, no deficit anyway, an experience happens that gets by our resources to be able to cope with it at the time. And so what happens is the experience gets laid into memory networks, what I call hot. And what I mean by that is that the experience, and this is obviously way oversimplified, but experience is basically composed of two parts. There's the feeling and sensation part, and then there's the cognitive part. In normal circumstances, what happens is those two things are decoupled, and we naturally resolve the feeling and sensation part. That's the juice, if you will, to the experience, so that we can take the rest, the cognitive part, and store it into normal narrative memory. That's everyday memory. So when you reflect back on something that happened in your life, you recall it, but your guts don't, clench up, and you don't break into a cold sweat or have a panic attack, etc. So when things get laid into those memory networks hot, a number of things happen. First of all, it takes additional resources to sort of maintain it, which then pulls energy and resources away from other things like attention, concentration, focus, and so forth. And
Uh-oh, you muted Dr. Holgis. So sorry.
I don't know how I did that. Sorry. Anyway, then it's like the memory network. Hello?
Weird glitch. I can hear you now.
Yeah. Okay. So the memory network sort of draws other experiences that weren't fully processed to that memory site, right? So what you get is this, it's like a buzzing beehive, right? Because it's all this hot stuff. And so anything that happens after that, that is in any way similar to that stuff, sort of pokes the hive, right? Well, you can't go into a beehive and poke one bee, right? You do that and the whole hive starts buzzing. So what happens is when people have an experience, and even in their estimation, they are over responding, it's because it's poking on the beehive, right? And getting it all stirred up. So there is additional reactivity that happens simply because of all this past stuff that's unresolved. So, and after a while, it really starts taking a toll. And in the extreme, you have things like PTSD, where it causes people to be hypervigilant and always on alert, and always anxious, overreactive, etc. And it takes a toll. I mean, at some point, your adrenals are going to say, "I quit. This is enough," right? And that has some pretty serious consequences as well. So, so what EMDR does, and there's parts of this that there's some theory to try to explain, but we really don't know exactly what happens. One of those pieces is when things get by our resources and get laid into those memory networks, well, why doesn't the brain just, seek it out and reprocess it and be done? Why doesn't it do that when it does that with most other things? Well, we don't know exactly why, but it seems like whatever mechanism processes this stuff as the experiences are coming in, gets disconnected from those stored things. And so they sit there, they suck up energy and so forth. So what needs to happen is new pathways to these memory locations need to be created. And that seems to be what EMDR does. And it all hinges on bilateral stimulation, that is, stimulation across the midline of the brain. And the way that we do that is either visually, right, or tactily. We use these things, I call them buzzies. They're just little, sensory things that go back and forth, or even auditorily with we used to call it a dichotic listening test, but it's sound that travels back and forth. But what it does again is just stimulate, one half of the brain or the other in sequence. And somehow, this is where, the theory gets thick, but the evidence gets thin. Somehow this creates new access so that your brain essentially can do exactly what it was wired to do in the first place. And so what happens is people do the bilateral stimulation, and they process through step by step, so that the internal reactivity connected with a memory is resolved. Again, it's that affective and sensational part that gets resolved. And they don't lose the memory. What happens is the memory sort of changes. And again, it's not as hot, if you will, as it used to be. And it seems like magic, and I am not a big believer in snake oil. In fact, Cassandra knows this about me, but I'm prone to telling stories, so I'll tell you one now, and there may be more coming. So back years ago now, it would have been, over 6 years ago. I think I went through the training either 6 or 7 years ago now. I forget exactly when. But I teach counseling students at Missouri State University and have for the last almost 20 years. In fact, I'm retiring from teaching at the end of this semester. And so I used to teach my students about this approach because I have friends back in Dallas who are early adopters and they would rave about it. And so I read up some on it, and I didn't really believe it, to be honest. And I thought I figured out how it worked, and it wasn't quite how the theory said it worked. So I, of course, I thought I was smarter than the, creators and all the researchers. Hubris knows no bounds. And so there was an opportunity that came up through a grant that we wrote to provide trauma treatment to the community at large down in Stone and Taney counties south of us, around Branson, if you're familiar with the area. And so I went to the training, and the typical training is composed of a couple long weekends with time in between so you can practice and get supervised. And so I went to the first weekend, and that's really focused on the fundamental skills. And so the first day and a half or so is lecture and, trying to orient you and bring you up to speed. And then you get to practice this stuff. And so, participants pair off and they pick some experience that still has some juice, and they work on it. So they practice the technique. Well, I happened to partner up with a lady in her late 50s, I think from Phoenix, a nice woman, social worker by training. And the event that she picked was something that happened to her about a year and a half prior, where she had been an avid walker, kind of power walker, and in fact, actually had even competed in power walking. And she said she was out walking one day, and she was walking through a neighborhood that she was not really familiar with. And apparently the sidewalk was broken up or something. And she tripped on something and did a face plant on the cement. Broke her nose, broke out a bunch of teeth, cut her up. And, she said she didn't feel it at first until, she went like this and looked at her hand, which was solid red. And then she freaked out. But what happened was that it scared her so much, it was so traumatic for her that she couldn't get out and power walking. Now she could walk normally, but she couldn't. Every time she would, get ready, she would get way too anxious and she'd have to stop. And that was a year and a half prior, and she still hadn't been able to get out and power walk. Now she got all the physical stuff taken care of in about 6 months. She had implants and her nose got fixed. In fact, she said it was even better because they fixed, some like a deviated septum or something. I don't know. But, so all the physical stuff was taken care of within 6 months, but the emotional impact was still there. So we started doing this, and the way it works is, you have somebody hold the memory, the image, the feeling associated with it, the sensation associated with it, and sometimes beliefs, usually beliefs about ourselves, about it's my own damn fault, or I'm stupid for having, that kind of stuff, derogatory self-statements. Oops, excuse me. I didn't turn my phone off here. What in the world? There we go. Sorry about that. So we gather these things up, right? And what you do is you have somebody sort of hold them in mind, and then you do the reprocessing. And so we do, and the way it works is you do a number of repetitions, and then you stop and you say, what are you aware of? What comes up for you now? And it's, things bubble up, and it doesn't seem to relate, but it's like archaeology in a way. You never know what you're going to hit as you go down through those memory layers. And so you just keep processing whatever comes up as grist for the mill, and then you work on that and you keep following it. And depending on the circumstances, you may do any number of sets, 6, 8 sets, 10 sets, and you take assessments along the way. And the way we assess is, I want you to hold this stuff in mind and tell me on a scale of 0, no distress whatsoever right now, all the way to 10, the most distressing thing you've ever experienced. Where is this experience? And so for this exercise and training, it was supposed to be somewhere around a 5. Well, this lady, it was somewhere around a 7. And so, we started the work, and, did, I don't know, we did 4 or 5 sets, I think, and stopped, and we did the assessment, and she was down to a 3. And I'm like, uh-huh. And I'm thinking, fortunately I didn't say this out loud, but I'm thinking, oh, this is the demand characteristics of the situation. There is no way in hell this is working that fast. And it's like, oh, that's good. Okay, well, let's keep going. And, we did some more sets, and we did this for about 45 minutes, I guess. And we stopped, and I said, we did the assessment again. And she said, I'm at a 1, maybe even a 0. And I'm like, there's no way in hell, right? I didn't say that though. So I said, oh, that's wonderful, great, okay, and so we went on to other training. I'm not believing any of this, right? I'm attributing it to all kinds of other stuff. And so we come back the next day for the last day of training. I check in with her. She's doing great. She's happy, smiling. She says, guess what? I went out walking this morning for the first time in a year and a half, and it was wonderful. And I'm like, okay, that's great. And so before we quit, I got her email, and I followed up with her about roughly 4.5 months later. And when she said she was doing wonderfully, still no distress, had fully recovered, that she still remembered everything. And so now the other interesting thing was, she said the image has changed. I still have the memory, but the image has changed. She said, when we were working, it was like this IMAX 360, Technicolor, in your face, really intense, so she couldn't hold it there for very long. And she said, now it's just a picture, right? Just regular color and a picture. And I'm thinking, this is weird stuff. I don't get it. And so in the meantime, I'm, practicing and so forth, and working with other folks, and they're reporting some similar things. And so it took me about 6 months after training to realize that there's something significant that's happening, that it doesn't reverse. And in fact, oftentimes things get better over time. So I'll give you another example. Within that 6-month period after I came back from training, I got a call from a former student who knew that I did trauma treatment, and knew that I had just gone through the EMDR training. And she said, oh, I could really use your help. She was in a new job. This was back when a couple governors ago, the governor had, just before he left office, had dedicated some monies to having our mental health authorities, the places that usually serve the indigent, hire liaisons to reach out to first responders, because there's starting to be an awareness that with everything that's happened, from 9/11 on, that our first responders were really suffering, lots of PTSD, and that's, fire, police, and military. Um, and so he wanted to grease the skids to try to get, open doors, because there's a lot of stigma in, police and fire and military as well about, seeking treatment for trauma. So she was the liaison in our area. She said, I have these two young cops that are in a bad way. They're going to, if something doesn't change, they're going to get fired. And the story was that these two young officers and a third officer were out on patrol. All of them were from different police departments, but they were all in the same area. And they were a bad guy, literally. And they were all within about 2 blocks of each other. And when one of them stopped a car on a traffic stop, as he walked up to the driver's side door, the passenger leaned over and shot him in the chest. Went down, the shooter takes off, the driver stays for a little bit and then takes off. Well, the other 2 officers hear the gunshot and locate it and get there immediately, but they get there in time to hold their, and 3 of these guys were friends. They get there in time to hold their friend as he dies in their arms. Now, as you can imagine, that's a hugely traumatic thing. Police department does what they usually do, what their protocol calls for, which is a critical incident debriefing afterwards. And they're struggling, but okay. And that's about it. That's all that happens from their departments. And so as time progresses, things get worse for these guys. They start having sleep problems. They start drinking more. They start arguing with their wives and yelling at their kids more. And their work performance goes down to the point where they're at risk of being fired. And so she gets them into me. And the first one, we did a preliminary session to sort of establish some rapport and get some information and set the framework. And then we did 3 sessions, just 50-minute sessions of reprocessing. And then we did sort of a follow-up wrap-up session. The other one had 4 active reprocessing sessions. And for both of them, by the end, they were both at a 1 on that scale I talked about. And I was amazed. I wasn't quite convinced, but I was amazed. And then I did follow-up with them, and both of them report dropping to a 0 and maintaining, and anecdotal reports from their departments are they are doing much better, and the real key is I ran into the wife of one of the officers later on, weird circumstance, and I just said, oh, well, how's your husband doing? And she was raving, oh, he's so much better. He's easier to be around. He's like the guy I met, yada, yada. I mean, on and on. It's like, you know what? There's something significant happening here. And so that's about 6 years ago now. And in that time, I've continued to work with a lot of first responders. In fact, I have contracts now with the Regional Firefighters Association to get them in, and have just gone through a whole spate of firefighters. I have contracts with the local police union, and am working with the violent crimes unit of the Springfield PD on a regular basis to help address anything that pops up. And the Springfield Police Department as a whole is considering opening, what I've been doing to everyone, including civilian employees. And we'll see what happens. I'm hopeful that will come about. And then in the region, various sheriff's departments and so forth send people. And so it's just sort of progressed. And I haven't, pushed this. I haven't advertised. In fact, because they're first responders, I cut them a great deal. And so, financially, it just doesn't behoove me to grow this business, but it's all by word of mouth. So all that to say, something significant is happening. Can I tell you exactly what happens? Not really. But what I think is happening is that, again, the reprocessing is separating those 2 essential components that didn't get separated when the memory was laid down, and it's resolving the hot stuff and letting the rest be stored into normal narrative memory. It seems to work for pretty much everybody. There are some folks that it doesn't work as well with. And we learned some of this through our grant that we had down in Stone and Taney counties, where we just work with the community at large. What I noticed from looking at the data was that individuals that through secondary markers, I would guess, have a personality, certain types of personality disorders, did not benefit as much, but therein lies the rub. Part of the impact of trauma, especially if it's early trauma, is disruption to attachments. And that is naturally traumatic for us. And all the personality disorders that the DSM still has, right, are all really about attachment disruptions. And so, I think part of what EMDR can help with is address some of those early attachment disruptions, which are inherently traumatic. But you have to focus on it, and it takes a little longer. And that's been the case for many things. EMDR is not the only way to treat trauma. There's a trauma protocol in cognitive behavioral therapy that in some ways is very similar. And there are some other approaches that are similar to EMDR, but EMDR and the CBT protocol have the most evidence, the most research backing. In fact, EMDR is considered a best practice by the American Psychological Association and by, or at least the equivalent evaluation by the VA. And it's interesting, the VA would be a prime place, and they do have some folks that do EMDR, but they've been a slow adopter. I still can't figure out why. So the only real difference that I can tell looking at the research between the trauma protocol of CBT and EMDR in terms of outcomes is that EMDR looks like it works a little faster. But in terms of the impact of treatment, they're equivalent as far as I can tell. So, not quite snake oil, but it seems like it. In fact, I had a firefighter just last week that I finished up with. I think we did 3 sessions, 2 reprocessing and 1 setting the stage. And stuff that had been dogging him, again, that got him drinking more, disconnected from people, et cetera, was gone. And when I told him, we did the assessment, and I said, okay, you're done. When I told him that he was done, he went, what? He said, well, how's that so? How can that? And I said, well, you're the expert here. Tell me, do the assessment. You still have the same distress that you had before? Well, no, I don't know where that went, but it's gone. So when you call this stuff to mind, when you hold that memory right there, do you have the same reaction? Do you have any bad reaction? He said, well, no. He said, that's weird. So he called it magic. I don't think it is, but and it's funny. I had, if you work with first responders at all, you'll know that, anybody that's on the job, whether it's police, fire, doesn't matter. After a while, the folks that have been on the job for a while, there is no way that they cannot sort of pile up those, even if it's not the big T trauma, it's the little T traumas, right? And it can catch up, and it sometimes it knocks them down, but usually it's just a drag. It's like a sea anchor, if you will, right? Just makes it really hard to move. And so I had, not long ago, I had a police officer, I think a 24-year veteran, part of the hierarchy of one of the police forces, come in and say, I'd talked to him before about this. In fact, he was instrumental in getting it set up for some of the officers in his police department. And he said, I don't have, some big thing, right? And sometimes there's a big thing. He said, I don't have a big thing, but there's a lot of smaller things that are just in the background and just hanging out. Is there a way that we can just sort of clear those out? I said, well, sure. So we did it, and we did, it took all of, I think, 4 sets of reprocess, 4 sessions, 4 sets of like, 20, 30 repetitions. And we stopped and we did the assessment, and he was, when we started, he was sort of in the moderate level, 4 to 5, he said. When we stopped, we did the same assessment. He went, huh, well, I'm at a 0. There's nothing. And I said, okay, you're done. He said, what? I said, well, yeah, if it's, you're done, you're done. He went, that's amazing. So, it's sort of gratifying when people you work with go, they can't be so, I got to be suffering more, and they don't. So that's sort of how it works, as far as I know. That's some of my experiences. What questions do you have about this stuff?
Have you worked
Have you
with
been exposed to this
people?
stuff before?
I was going to
Lauren,
ask,
say again.
yeah, if you've worked with people that went through the Joplin tornado and if environmental traumas respond the same.
I have some, not as much as I thought I might. And it's interesting that what happened with the Joplin tornado is similar to what happened with Hurricane Katrina. And I went down there to do reclamation work. I didn't do mental health stuff, but I went down. So I was able, over the long haul, over years, I was going down, and I got to know people down there. And the same thing that happened there happened in Joplin. And that is, the tornado first hit, there was this flood of people down there. So like with Katrina, within a month of the hurricane, there was this flood of mental health practitioners of all sorts, psychologists, psychiatrists, counselors, social workers, you name it, going down to help. Well, but it was so early on that people didn't identify that they had trauma. It hadn't sort of settled in enough that it was really dogging them pretty bad. And so a lot of mental health practitioners went down, they sat around, they played cards, but they didn't get to practice their trade. Same thing happened in Joplin. There was a rush of people over there. And I remember when it happened, I was talking to a colleague who was going to go over, and I said, my recommendation would be to, make sure that they're doing critical incident debriefing with everybody at the time. And there's some mental health first aid that does help immediately. But I said, monitor and go back about 4 to 6 months from now and be ready to take people in and do trauma recovery work. And sure enough, that was about it. And at about the 6-month mark, started to see more folks needing services, being in great distress. And then since then, it's increased. But fortunately, there have been resources around, so people were coming in to do the work.
Thank you.
You're welcome. What else you want to know about?
Do you notice that a lot of your patients are on medication therapy too, in like adjunct to this, or that this kind of solves things up for them?
Yeah, lots of folks, I mean, especially if they've been struggling with the impact of trauma for a while, they get put on all kinds of stuff. But as you're probably aware from the literature on PTSD, we really don't have medications that are very effective, right? But what happens is usually the progression is something like this. So they go into their doctors because they're not sleeping. So the doc says, oh, well, let me give you this trazodone, right? And so they get on the trazodone, which, by the way, mucks up their sleep architecture even more, right? But it helps them sleep some. So some is better than nothing, right? And so they're on for a while, and then the anxiety starts up, and so the doc puts them on a benzodiazepine, and then the depression sets in, and so they give them SSRIs. And so by the time I see people, oftentimes they're on a cocktail. And so I say, follow your physician's advice, but let's see if we can take out the emotional reactivity that necessitates some of this stuff that's not really working anyway. And then I tell them to talk to their doc to start titrating them off. You know, there's this seems like it might be, you know, the purview of psychologists like myself or counselors or social workers or whatever. But if you're going to work in like family medicine or the ER, anything like that, this is a nice skill set to have, because you can use a variety of these skills immediately with people, right? And they can be very helpful. So I would encourage anybody that's interested in looking at the training. There's resources out online. There's actually two organizations, both started by Francine Shapiro, who sadly is dead now, but the work goes on. One is EMDR Inc., which was her site that she started, which is sort of more academically oriented. And then there's an international organization, EMDRIA, EMDRIA, the international organization. And at both sites, there's a listing of, actually, they have listings of therapists in your area and stuff like that, so that it's a resource guide too, so you can find out who's trained and so forth. And then it has listing of training sites, and the trainings are done around the world. So in fact, we now have, there's a group in St. Louis that does it in a slightly different way. Instead of doing the traditional 2 weekends with some time in between, they do everything in a 1 week block, including the supervision. And it's actually a little less expensive than the other. And there's two trainers here in Springfield that periodically do trainings as well. And so there's more that's springing up, and they actually do have some other training that's what do they call it? HAP, humanitarian assistance or something. It's really training that's it's the same training as everybody else gets, but it's specifically for folks that work in agencies or, you know, not for profits and so forth. And it's deeply discounted essentially, but it's the same training, follows the same protocols and stuff. So check in your area and see. I would highly recommend it. It's worthwhile skills to develop. What
So
else you want to know?
who is eligible for those trainings? Is it like any medical professional, or do you have to be a doctor, nurse? What is the requirements for that?
Actually, any kind of service provider can do it, but if you're a student, you have to have a sponsor, a faculty sponsor. So for instance, I'm currently sponsoring one of my students who's about to graduate to go to the training here pretty shortly. But when I was in training, I was in with physicians of various sorts, social workers. There's a couple other psychologists. There's a lot of counselors, like LPC types. So, and you don't, let me see, I think it's the case, you don't have to be independently licensed. But if you're not fully licensed, then, you know, you'd be under supervision by somebody and they would have to vouch for you. Here's what I noticed about the training itself. Anybody can go through the training and benefit, but the folks that have decent clinical skills, interpersonal skills, are going to do the best, because as you might imagine, you know, most of what you're doing depends on how you establish connection with the client. Now, it doesn't take the same depth and breadth of connection as doing psychotherapy per se, but you have to establish some trust and safety and set the right frame. And then, so what I've noticed is that folks that are decent, you know, therapeutically overall tend to do the best with this.
Thank you.
Dr. Holgus, can you
Sure.
share with us an experience that you might have had in its impact with the youth?
Yeah, as a matter of fact, it hasn't been too awful long ago. I was working with this high school student, and he was let me see, when I started, he was a sophomore. And what had transpired was he was at school like about a year or so earlier, So he would have been a freshman. And there was this guy that used to go to the school he was at in a parking lot. And for some reason, the guy just walks up to him and cold cocks him. I mean, in the nose, lays him out, right? Breaks his nose, breaks his jaw in the process of all this stuff, so that this kid, has to go through major surgery and stuff to reset his jaw and all this. And, afterwards, he started to develop some symptoms of PTSD. He was hypervigilant, he was having sleeping problems, et cetera, et cetera. And it had progressed until his parents started calling me and saying, we're worried, that he's going to get self-destructive and so forth. So came in, did an orientation session, and pretty much did what I do with everybody. I mean, I've worked with a lot of kids, adolescents and beyond, really, over the years. So, there's some tips and tricks around that stuff, as you might imagine. But I just, tried to develop a relationship with him, and we did the reprocessing, and he completely cleared everything out in, well, really he did in 2 sessions, but we had 4 sessions overall. The first one, again, was orienting and getting him ready, 2 sessions of reprocessing, and then the last was more just psychotherapy, was sort of the cleanup, because the trauma was gone. And so the way that you work might shift a little bit. There are specific guidelines for working with younger kids, but you can use EMDR with kids as young as like 3 and 4, but you have to have a very particular skill set. So it's sort of like, I mean, I don't know that this is totally accurate, but it's like the skill set that you would need to do play therapy, for instance. So for instance, there's a colleague of mine that's up in Omaha, Nebraska, who does this kind of work and works in a team where they also can bring in a family therapist. They do attachment work. Deb Wesselman is her name, and she's written a couple different books. The latest book specifically addresses working with kids and how it fits with attachment stuff and so forth. So I would highly recommend it if you're interested in that. But they have developed specific methods about how to do the things that we do in EMDR, like that 0 to 10 scaling. That's really tough for a kid, especially a little kid. But they figured ways of, putting, like different drawings of, faces and stuff out there and saying, what fits you right now. So it still works. And it's an amazing thing. In fact, Deb says that kids work a lot faster than adults, basically because, they don't have the same kind of defenses and things built up.
So it could be a very great application for pediatrics as well. That's awesome.
Yep, absolutely. In fact, if you're out there in pediatrics and I would encourage you to consider doing integration, where you integrate mental health into the pediatric practice. This has been years ago now, but we did a federal grant looking at some of the models of integration, and our site was a fairly large peds practice here in town, and the data was astonishing in terms of improvement and quality of treatment and so forth. But sadly, it's all about reimbursement, right? So, the reimbursement structure still does not support that. But if you got trained in EMDR, if you brought in somebody who's trained in EMDR, you could do a form of integration where you don't double up on the time, but then you make the direct referral to somebody in your office, and instead of, giving them an appointment, you walk them down to the office. And so, yeah, it can work. What else do you want to know about with this stuff? Or actually, I don't know how often you get to talk to a psychologist. So what do you want to know?
Is there any use for EMDR for conversion disorders or psychogenic seizures or things like that?
There are protocols written for EMDR to work with those kinds of conditions. I have not done that directly. I know of Now this is a little off, but like dissociative identity disorder, right? That kind of, very significant dissociative disorders. And I sort of think about conversion disorders sometimes in the same frame. But I do know there's an EMDR therapist, a psychologist out on the West Coast who specializes in that. And so there are protocols written for how to work with folks with DID or who are highly dissociative otherwise. And I would think that those same protocols would work with conversion disorder.
Thank you.
Sure. What else, y'all?
I have one more question. Have you ever worked with any kind of like pharmacists that have been trained in doing this? I'm in pharmacy school, so I'm just personally interested.
Oh, cool. Not directly, but I can see where it would be of great benefit because you're going to encounter lots of folks who have significant trauma histories, right? And so, if nothing else, just being aware of how this works might be an aid to the folks that you work with. That would be, I hadn't considered that before, but boy, that would be dynamite.
Yeah,
I actually do have a.
Oh, go ahead.
Go ahead. I'm sorry.
I was just thinking
Go
because I
ahead.
have a rotation at the VA and how you mentioned about their practice site actually has a lot of autonomy for pharmacists. And so it would be really interesting, even just in class, we hadn't learned about any of this. The DSM-5 doesn't really cover or mention anything like this, or at least from what we had learned. So it's a nice tool to have in my pocket.
Absolutely. Yeah, as a matter of fact, DSM-5, when they, revamped the 4TR, they came up with just two stress-related disorders, right? So you have acute stress disorder and PTSD. Well, gee, there's the interesting thing is that when the work groups were still doing their stuff in preparation for coming out with the DSM-5, there was a national work group separate from the American Psychiatric that lobbied them to include directly trauma-related disorders, right? One for kids and one for adults that was different than PTSD or acute stress disorder, which really has gotten, for the most part, has gotten associated with combat stuff. And there was lots of evidence to support a diagnosis like that. But, politics being what it is, they came back and said, well, we don't think that this area is mature enough in its research, which was not the case really. But there was some other political something or other afoot. So yeah, the DSM doesn't say anything about this stuff, which is sad. But just wait. There'll be a DSM-5R or DSM-6 before long. So.
Has there been a head-to-head?
Can I ask you all a question? Oh, go ahead, Daniel.
Has there been a head-to-head comparison of the different modalities with EMDR, like say the tactile with the buzzers, the hearing, or the light?
Actually, it's interesting you should mention that because about 5 or 6 years ago now, there was a sort of a growing consensus among practitioners that, oh, you really don't need to do the visual, you can just do the other modalities. And so in fact, there was some research undertaken to see if, use of one modality or the other, or dropping a modality would, perform just as well or better. And what they found was that the visual still seemed really important. And so, and what I've noticed clinically is, I rely on the visual and then I will accent it, if you will, sometimes with the tactile. Although in the age of COVID, I've had to stop doing that. So, maybe after we're past the pandemic, I'll start doing that again. But yeah, the visual still seems to be very powerful. And I think it's a preferred method. So let me ask you all a question then. So do you, in your clinical experiences, are you encountering stuff that you identify as trauma-based?
I think when you mentioned the little t versus big T trauma, I mean, some people do have those large T trauma events where they're really like scarred by it, but I think everyone can think of little T traumas throughout their lives that they can assess and see some kind of need for this for sure. And definitely people that struggle with mental
Yeah.
health will could definitely pick out things in their life too.
Yep, absolutely. Absolutely. Yeah, it's sort of like, anybody who, especially as a kid, witnessed violence in the home, had, violence done to them, even if it was just, sort of extreme, physical punishment, for infractions. Certainly anybody who's been sexually abused, anybody who has been in a really bad car accident. In fact, I had a young student, it's been a couple, 3 years ago now, graduate student, who was coming home one night late and got T-boned by somebody on a highway. It's one of those highways in Missouri where you can cut across, which just seems insane to me. Anyway, he got T-boned, and fortunately at the last second, he jerked the wheel a little bit and it saved him and his family, but it scared the life out of him. And so we did EMDR. Within 6 weeks of this happening, we were doing EMDR to clear that out. So, he could drive again, essentially. So anybody that's experienced significant stuff, and essentially the way that you tell if there's something that might be worthwhile to clear out is if you sort of float back through memory and, these things that happen in life. And when you come upon it, you're going to come upon things that were impactful. But if you think about it and you go, wow, yeah, I remember, that was really hard at the time, but your guts don't, seize up, then you've probably processed through it. And again, most things we process through naturally. But if you have something that when you think about it, you feel that strong visceral response, then that's probably something to clear out. And that's sort of my marker for folks, right? Because, oftentimes people go, yeah, I know there's stuff there, but I don't know what it is. And it's like, okay, well, let's start someplace. And the nature of this thing, is such that, you can almost start anywhere you want and it'll lead you to where you need to be. So, questions, comments? Yoki dokie.
If
So,
everyone would,
Cassandra?
oh, go ahead. If everyone would go ahead and take a look at the chat really quickly, there's a link to the evaluation and the program ID is 30144. If you would just take a minute and give us some feedback on that. If no one has any other questions, we sure appreciate you today, Dr. Holgus. It was great. Great interaction today. I love all the questions. I think this is a huge benefit and something that if you are just very interested in, you should hone in on that and, try to find out more, possibly get some training. Think about all the applications of what we could do with this and how impactful it can be for so many.
I do want to mention this. If you want to get a feel for what this is like and how it works, there's a real old, out on YouTube, there's a real old segment of 2020, the TV magazine thing. I mean, that's probably so old, it's not around anymore, with Hugh Downs, right? So that tells you how old it is, but it's from the early 90s. And what they do is they interview Francine Shapiro, and then they talk to several different folks, couple folks who went through EMDR. One was a non-combat vet and the other was a rape survivor. And then they talked to some other practitioners, one guy at the VA. And anyway, it's a pretty good segment, and it gives you sort of a feel for what it's like. The only thing that doesn't apply anymore is at the very end, they say, well, it's still controversial and the research base is not there. And that's not true anymore. We have almost 30 years worth of research now. So, but it's worthwhile to watch. It's not that long.
Great.
Thank you, Dr. Holden.
Thanks for having me, y'all. It's good to meet you. Good
Thank you.
luck.
Thank you so much. Have a great weekend.
Thank you.
Y'all too. Enjoy the sun. Stay safe. Wear your masks.
Take care.